Okay, great. I think we'll start. Welcome. I'm Jeff Miller. I'm one of the co-directors of Grand Rounds with Kate Elkington and Christine Denny. We're very pleased that those of you who are here in the auditorium are joining us in person today, and welcome to our Zoom webinar attendees as well. A few announcements before we get started. Next week's Grand Rounds will be the Viola Bernard Grand Rounds. Our speaker will be Omar Gudinho, PhD, Director and Associate Professor at the Clinical Child Psychology Program at the University of Kansas. The title of the talk will be Disparities and Mental Health Service Use of Latinx Youth, Identifying and Responding to Youth Family Needs. At the end of today's talk, we invite everyone in the in-person and Zoom webinar audience to ask questions. We try to prioritize trainee questions, both in the room and on the Zoom webinar. If you're on the webinar, the way that you can ask a question is by clicking the Q&A button at the bottom of the window, which is different than the chat. If you're a trainee, please put the word trainee at the beginning of your question. And if you are a Zoom webinar attendee, we encourage you to ask your question yourself. We will, if you're open to doing that, we will temporarily promote you to a panelist on the Zoom, and you can ask questions camera on or off according to your preference. So at the beginning of your question in the Q&A, please write, "Can ask question myself," or prefer to have my question read. Okay, with that, I'm going to hand things over to Dr. Lisa Dixon, who will introduce both the Essick lecture and today's speaker.
Thank you so much, Jeff, and I'm so excited to be here. This is really one of the most fun days of the year when I get to introduce the Essick Lecture Awardee. So I'm going to start by just talking a little bit about the person who has really influenced this department and this program and has brought to us the kind of research that impacts people every day, Dr. Susan Essick. Dr. Essick is a retired member of our faculty, professor and first director of the Division of Mental Health Services and Policy Research. Dr. Essick's career emphasized facilitating the translation of research findings into mental health policy and practice, addressing problems faced by mental health administrators, and evaluating the impact of behavioral health services delivered in routine practice settings. Her grants, papers, awards, activities, of which there were many, shared the theme of sort of service and government service and rigorous research. A common theme in her research has been creating scalable ways to implement new services, monitor implementation fidelity, and anybody who knows Susan knows that implementation fidelity is a very, very important part of her approach, and measure outcomes to assess the extent to which the intended services are indeed those being delivered. She studied messy problems in messy contexts, determined to find simple truths that could be applied. She was also an incredible leader, a chair of too many committees and programs to count, and she thus endowed the Essick Lecture to be given by a scholar whose research has had an impact on mental health policy making. Past award recipients have included our own Dr. Melanie Wall, who was the first, Dr. Colleen Barry, who is now inaugural dean of the Cornell Jeb E. Brooks School of Public Policy, and our own Dr. Roberto Luis Fernandez. I'm glad to introduce the fourth recipient, Dr. Pat Areán. Pat's academic journey included receiving a PhD from Fairleigh Dickinson University in clinical psychology. She did her internship at Bellevue, which I thought was kind of cool. Thereafter, she headed out west to UCSF, where over time she became full professor. I did want to mention there were a couple of notable activities I saw on her CV, which she participated in while she was in San Francisco. She was the volunteer co-instructor of the UCSF Taekwondo. And she was also leader coordinator of the Super Hikin' Mamas Club in San Rafael. So as much as it might have, it did not inhibit her, those activities, from moving to UW, or otherwise known, we could say in these parts, UW, in 2015, where Pat is currently a professor in the Department of Psychiatry and Behavioral Sciences at the University of Washington School of Medicine, where she is an associate director of behavioral science and technology. She is recognized as an international expert on the effectiveness of behavioral interventions for mood disorders in special populations, such as older adults and ethnic minorities. She has a long list of papers, presentations, and awards. I won't, we want to hear from her, not hear about her. So I will, but I do have a few more notable comments. She does work in a variety of service settings: mental health, primary care, senior services, and mobile platforms. Her team integrates cognitive neuroscience, socioeconomics, and implementation science. And those are such cool things to integrate. She leads the so-called UW CREATIV Lab, which focuses on personalized interventions designed to improve the mental health and well-being of people as quickly and as easily as possible by developing targeted, streamlined behavioral interventions that clinicians can easily administer and are readily available to a broad array of patients. And I think that you can see how Pat's work is such a great fit for the Essick Lecture and the Essick Award. With that, I will ask Pat to come on up, and we're eager to hear what you have to share with us.
So things are happening on the screen here. I'll get started in a second. I'm really pleased to be here and honored to be a recipient of this award. I've always admired Susan's work, and I'm very flattered that I get an award named after her. So thank you very much. And so what I'm going to be talking about today is research that we're doing in the University of Washington ALACRITY Center. I've been directing the center for the past 4 years. We recently got notice of award for another 5 years, but I have handed over the leadership to a junior, not totally junior, he's a professor, but a younger faculty member, Aaron Lyon, because over the initial first 4 years of the center was really focused on the integration of psychosocial interventions into primary care medicine, but a lot of our pilot funds were funding initiatives in schools settings. And so Aaron is an expert in the implementation of behavioral interventions into schools and pediatric health. And so he's now the director of the center, and I get to sit back and watch him take the lead on that. So today, what I'm going to be doing is giving you a really brief overview of the implementation challenges that we have with evidence-based psychosocial interventions. Many of you are probably already aware of what those are, so I won't spend a lot of time on them. It's really just to set the stage for the main purpose of the talk, which is to discuss how our center has been using methodologies from human-centered design and human factors to improve the usability of psychosocial interventions for frontline clinicians. And I'll talk about a couple of examples of how we've implemented those methods successfully at the ALACRITY Center in my institution. So, the first thing I want to start with is that, there are a large array, a long list of psychosocial interventions and psychotherapies that are effective for treating major mental illnesses in children and adults and older adults. And there is so much data in support of these interventions that around the world, there is great infrastructure being implemented to ensure that anybody who's seeking services, particularly psychosocial services, have access to interventions like cognitive behavioral therapy, problem-solving treatment, and interpersonal therapy. The United Kingdom is actually a really great example of that. There's a lot of complaints about what the National Health Service does, but one of their shining gems in their system is the increasing access to psychotherapy treatments or psychological treatments, where they have invested quite a lot of money over the past 20 years in making sure that clinicians who do psychotherapies or provide psychotherapies as part of the National Health Service are actually delivering evidence-based psychotherapies. The VA here in the United States is one of the few organizations that have also invested quite a bit of money in creating an infrastructure to ensure that veterans have access to evidence-based treatments for things like depression, substance abuse, and PTSD. When you think about the proportion of people who are seeking mental health care and ask them whether or not they would use psychosocial services, a majority of patients would say they would like to have that as either their primary form of treatment or in conjunction with other types of treatment. So it is a preferred model of mental health care. So given all of that, we have these a long list of really effective treatments, that there's international acceptance that these should be frontline treatments and that patients are willing to use them, you would think that access to quality care here in the United States would be easy. The problem is that here in the United States, we have a very limited infrastructure for supporting evidence-based treatments. And that's not just psychotherapies, it's pretty much across the board, but it's particularly bad when it comes to the psychosocial treatments. And some of the work that Marina Weissman has done over, I think repeatedly, she's demonstrated that our educational programs vary widely and how they support or even prepare the workforce for delivering these treatments. You can go to UPenn and learn CBT from, a while ago, originally the late Aaron Beck, the person who created cognitive behavioral therapy. But if you go down the road to say maybe Hahnemann University, that wouldn't be available. And so that just gives you an idea of even geographically, there's a lot of disparity in how educational programs support these or develop the workforce. Once you go through the training, licensure doesn't really help either. Most licensure for clinical psychologists and for social workers is based on whether or not you can pass an ethics test. It varies from state to state. So in some states, the ethics test is all you need for your license. In other states, maybe you take another written test to get at, how you report child, abuse or elder abuse specific to the state, but nowhere do you see anybody testing the competencies of delivering psychosocial treatments. So it's not part of being licensed. Ongoing quality assessment is also impaired in this way, and that is literally continuing education credits. All you have to do in my state is have 36 continuing education credits every 2 years in order to get your license renewed. And those credits, as long as they're approved by some accrediting agency, can vary from, ethical management of electronic health records to the use of hypnosis and crystals and helping people with chronic pain. So, again, even the educational offerings for continuing education is not very well regulated. Even if you could do all of that, like have everybody credentialed and, trained and supported in delivering evidence-based treatments, our billing codes are set up in such a way that all you do when you're doing psychotherapy is you pick the code for doing generic psychotherapy, and it's based on the amount of time you spent with the patient and whether or not their parents were in the room, the couple was in the room, or is it group therapy? And there's literally nothing to do with whether or not you were using an indicated intervention for the disorder that you're treating. I was working with a group in the United Kingdom on a digital mental health tool, and they were asking me, how do you bill for mental health services or psychotherapy in the United States? When I explained to my colleague how that worked, he started to chuckle. He goes, we stopped doing that in 2005. And so when you think about it, all of us, it's like, 2005 wasn't that long ago. It's almost 20 years ago. We are literally 20 years behind the United Kingdom in the support of evidence-based practices. We also have another problem, and I'm sure you all are aware of this, is that we have a real disparity in terms of access to, qualified trained providers. And so this is a map for high priority service areas in mental health across the United States. The lighter blue colors indicate serious need, that there are very few mental health providers. The darker areas are a bit better. But you can see that there, particularly in rural areas in the South, there's a lot of maldistribution of the availability of psychologists, psychiatrists, and social workers. During the pandemic, the need for mental health services was really amped up. And a lot of my colleagues who run digital mental health companies were getting slammed with, requests for care. The thing they encountered is that there wasn't enough of a workforce to really address the needs that they were experiencing. In fact, some of these companies ended up in the news as providing bad care. But when you really look under the hood, it's not so much that they were, well, yeah, the care that they were providing was compromised because their clinicians were overloaded by the massive amounts of requests, and they couldn't find any other clinicians to fill in the much needed slots. But even though technology did increase access to care for a lot of people, it's not really a panacea, because in those very same states and counties where you see a maldistribution of mental health providers, there's also a big digital disparity or a digital gap. And so this is kind of a complicated map to disentangle. The pink squares are counties that have access to health clinicians. The blue counties are where you see access to broadband. So in this case, this is internet adoption. So people who are using Wi-Fi, and the purple squares are where you have both internet, people are using the internet, and there's health providers. You can see there's the accessibility of internet use is really low in many areas of the United States. In fact, it's largely because there's poor broadband access. For instance, I was trying to do a study with the state of Wyoming through our center, and we were trying to talk about, like, could we use technology to reach your frontier and rural, clients? And they basically said, our clinicians don't have reliable broadband or Wi-Fi, so guaranteed the patients don't. So this is a real challenge that I think some of my colleagues who are in the technology field talk a lot about, technology erasing disparities, but that's actually not the case. There is a big digital divide that needs to be addressed. What I'm going to be talking about mostly today, though, is the usability of psychosocial interventions. So when you think about when interventions like cognitive behavioral therapy and interpersonal therapy were designed, these were designed for systems of care that were very much like a private practice setting, or like a clinic setting where you had the opportunity to sit down with a client for about 50 minutes, some time left over to fill out your notes, and then move on to the next client. And they were usually designed to be delivered by people with a PhD or an MD. However, most people in this day and age are seeking services in settings where there aren't PhDs available, and that the demand on time is such that it's really difficult to actually do evidence-based treatments the way they're designed. So very few people have that 50-minute hour available to see a client. A lot of these interventions are designed so that you see people once a week. When you think about cognitive processing therapy or exposure therapy, those are actually 90-minute sessions that are supposed to happen a couple of times a week in the first, the early stages of treatment, and then weekly thereafter. But a lot of my colleagues who work at the outpatient clinic at University of Washington say that unless they control their calendar, which a lot of clinicians do not, they're less likely to see their patients more than every other week. So there's a real pressure on the design of our interventions that make them difficult to do to high quality in our current mental health system. Clinicians that I've been working with through the AIMS Center have also complained that the interventions are highly complex, that there's a lot of steps going on. It's really burdensome for them to deliver. And so it makes it very complicated for them to utilize with the patients they're working with. They also complain about there being poor contextual fit. So like I said, it doesn't fit into the normal workflow. It doesn't address the way that they see patients. And so while some clinicians will say, I see the value in learning this evidence-based practice, but the way you're teaching it to me, I could never do in the setting that I'm working in. So in summary, there's no one sole reason for why evidence-based psychosocial interventions are not well adopted in the United States. And there are a number of implementation solutions we could address, such as regulation over training, providing incentives to provide specific services, maybe amping up technology or figuring out how we can deal with the digital divide. But this is going to take a very long time to put into place. So what our center has been focused on is really making sure that the interventions can be designed such that frontline clinicians in primary care medicine and senior services and schools can actually use them with their patient population. So I'm going to spend some time now talking about evidence-based psychosocial intervention usability and human-centered design. So what do we mean by usability? This is actually a term from human factors, and it refers to the ability of a user of a tool to actually pick up the tool, learn it quickly, and use it with high quality and high fidelity. So this is something that we really want with our behavioral interventions. And what influences usability are things like complexity. The more complex the tool, the harder it is to use. This influences learnability. So if there are a lot of components on a tool or a lot of complicated components in a tool, then it makes it harder for somebody to just pick up and learn or learn quickly, right? A tool that's usable is generally considered flexible or error tolerant, so that if you accidentally make a mistake, the tool can bounce back. What we hear a lot from our clinicians is that they don't feel that the evidence-based treatments are flexible enough. Part of that has to do with learnability. When I learned how to do cognitive behavioral therapy and problem-solving treatment, I learned from the experts. That's all I saw were patients, just repeatedly using this intervention. And so as I got proficient at it, I learned how to be flexible with it in a way that wouldn't violate its validity, its fidelity. But a lot of these clinicians don't have the same supports. They're often post-training anyway, so they're not being supervised by anybody other than the trainer. And so this is why they feel like it's not error tolerant. That makes the interventions less engaging. All right. So a big piece of usability or human-centered design is making sure that the tool you develop is sticky and engaging, that it addresses certain goals or values that the user has. And so, because if the intervention doesn't have those values, then the clinician isn't going to use the intervention. And then obviously I've talked a lot about contextual fit, that it needs to be able to be part of easily adopted into the workflow and with the types of supports that clinicians would experience in their setting. Human-centered design is a field of engineering where I kind of consider it as community-based participatory research meets marketing and design. It leverages very heavy on the importance of the end user being involved in the identification of the usability problems of a tool and in developing the solutions for the tool. It's a little different than just straight CBPR. That's something I've done pretty much throughout my career. And one of the big differences is that even though I would talk to clinicians and patients about evidence-based practices and even talking about the match with their values, I was usually the one who went back and made the adaptation and tested it. In user-centered design, the clinician is actually the one that does most of the redesign solutions. And our job as experts is to really just make sure that they don't remove some important ingredient in the treatment. And if they do, that there's a strong rationale for it. Okay. The methods are pretty similar to a lot of what people who do community-based participatory research use. So there's a lot of survey methodology, A/B testing, which is basically just comparing different types of solutions to each other, measuring how usable they are and moving on, selecting the winner of that. Some of the more important aspects of human-centered design are these processes called active inquiry, where the user and the researcher basically walk through all the tasks being performed in the psychotherapy. And you can do a cognitive walkthrough where as you're going through the therapy with the representative clinician, you get a sense of what's getting in the way of their understanding the utility of the different aspects of the therapy. Or you can do a think aloud where they basically role play with you being a therapist using this intervention, and they stop and they tell you why or why not they think this particular strategy wouldn't be something they would use. You collect all of that information and then create, a cognitive, a concept map that kind of demonstrates what the flow of treatment is like, where the pain points are in the delivery of the intervention, and then potential areas for developing solutions. And then you engage in a participatory redesign session where this is all laid out, and we work with the clinicians to design wireframes or new structures for the therapies to make sure it addresses their values, includes the therapeutic elements, and is also something that would fit in the way that they deliver care. I didn't talk much about passive inquiry. This is actually a really interesting tool, but it's fairly time intensive. What you would do in passive inquiry is have clinicians videotape their psychotherapy sessions, using the evidence-based treatment. And then at the end, you would sit down and watch the therapy with the clinician and ask them questions about let's stop here. Why did you ask the question that way? Tell me a little bit about your thinking about what happened here. I noticed you missed a step that's in the normal process. Was that an accident? Was that intentional? What was your reasoning for that? So that's very labor intensive, by the way, because therapists tend to be pretty unique in some of the reactive adaptations they engage in. So this is the model that our center uses. We start with a discovery phase where we try to identify what the pain points are in delivering the intervention. We work closely with clinicians. Sometimes it's clinicians and patients, because oftentimes the patient is also the pain point, and try to engage in this iterative redesign process. And then we always compare the adapted intervention or the redesigned intervention to the parent intervention in terms of its usability, how well, basically clinician drift in using the new intervention compared to the original intervention, and on clinical outcomes, because that's critical. Our goal is to reduce the number of reactive adaptations that clinicians engage in when they're using these evidence-based practices. This is work that my colleague Shannon Wiltsey-Sturman has done at Stanford quite a bit, sort of looking at how clinicians modify treatments as they use them with different patient groups, identifying that there's an awful lot of reactive adaptation that is sort of on the spur of the moment, often involves people like stopping the evidence-based treatment and doing something different. And the argument in the field is basically we want to reduce the number of reactive adaptations and increase and create more proactive adaptations based on what are the common pain points we see in using these interventions. So now on to some data and example. So this is actually an interesting study. I did this design work before we had the ALACRITY Center. I started it when I was at UCSF, and did this project in collaboration with George Alexopoulos and Patrick Rowie at Cornell University. And the impetus for this study was that we had been studying problem-solving treatment for late life depression for a number of years. When it's delivered well, is a very effective treatment, is particularly effective for people with older adults who have major depression and executive dysfunction. We have a nice paper that shows that the number needed to treat for PST is 4, which is a huge effect size. And this was in a sample of 220 older adults with this type of major depression. But we had a second study where we were trying to use problem-solving therapy in disabled adults who were living in low-income areas, in our case, this was in Oakland, and we were working with social workers who were part of a Meals on Wheels programs, because we figured that that's a great way to utilize this existing resource, teach them problem-solving treatment, and see if they could move the needle on, depression and social isolation in this population. And one of the things that we discovered is that we were spending an awful lot of time retraining the social workers in PST. So we'd train them to competency. Then we'd listen to some of the tapes that they were, audio tapes, and we'd be like, okay, no PST is happening here. And we'd come back and say, no, you have to, it's a study, you have to do this. And finally, George got so frustrated. He's like, you need to simplify PST. There's something wrong with this. Patrick Rowie, who's a clinical psychologist as well, and he was trained by Tom Desarella, who is one of the creators of problem-solving therapy. We both looked at each other like, how do you make it more simple? And then we decided, why don't we talk to the clinicians and figure out what's going on? So in our discovery phase, the first thing we did is we surveyed about 60 clinicians who we trained both in PST or in CBT. We needed to enrich the sample with clinicians who were doing evidence-based practices. And so this is published data that one of my former postdocs took the lead on. And a lot of the survey that we did was about, are you still using these interventions in your practice? When do you use it? When does it not work? Like, when does it start to fail for you? And what are, go ahead, tell us, we want to know, what are the typical ways you've adapted these interventions or integrated them into your usual practice? We took that information, and additionally, there's a step that's missing on this slide. We also looked at case notes from our studies in both at the Impact Center for the Impact Study, which was one of the first collaborative care studies where we trained nurses and social workers in primary care medicine in the delivery of PST and problem-solving treatment. And also in some of my other studies to also look at how did the flow of treatment seem to go? Like, under what circumstances could we tell in the note that the patient was actually responding well to treatment or not responding well to treatment? So we could kind of identify some barriers to the success of the intervention. We then took all that information and we identified an additional 10 representative clinicians in aging services, and we presented to them the challenges and the changes the survey and our notes identified, just to kind of confirm our findings. We then sat down and talked to these clinicians, and basically this is what we found. Most clinicians felt like, and this is an engagement piece, that is sort of like a non-specific factor, but it's important for the therapist to be engaged with the intervention, is that they really missed having time talking to their patients, that they felt that the intervention got in the way of that because they had to check all these boxes, and that, yes, I know I want to help them solve their problems, but I also want to get to know my patient. I have a way that I talk to people, and that's why I got into the field. I didn't want to be like some engineer just going through the process with patients. I want to know, I want to work with them. I want to be part of their ecosystem. So that was like a big thing that Patrick and I had to sit down and say, well, if you're really good at PST, you can do that. But what we were finding is that nobody was using PST enough to become flexible enough to add in that opportunity to get to know their patients. A lot of clinicians either removed steps in the PST process, and we tried to evaluate whether or not these were, really critical steps that were being removed. But the most common thing we saw is them combining steps so that they could get through the PST process faster. We also noticed that a lot of clinicians, when they're working with older patients, don't go right away to the problem list that they generate with their patients. They all start with some kind of really light behavioral activation thing, like, why don't you go out for coffee this week? Or why don't you, straighten up your house or something, or go for a walk? So very simple behavioral challenge. And that most of the patients or the therapists, when they use PST regularly, it was for those clients that seemed to do very well with that initial behavioral challenge. So if they didn't run into any kind of obstacles from the patient, then they're fine using PST because it becomes very easy at some point to do. But there are clients who it's very difficult. Either they have a difficult time identifying what goal to work on. They have, and I'll show you some of the barriers. Let me skip to that. So they are patients who are particularly negative in their evaluation of their success around doing a behavioral activation challenge, or pessimism about whether or not they'd ever get better. Patients who had a lot of affective dysregulation in the session were also very difficult to do PST with. And so oftentimes the therapist would just abandon the therapy and sit and do a lot of supportive therapy. A lot of times that was appropriate. Other times it really got in the way of the client having any exposure to an evidence-based treatment. And then clients with low motivation that would just come back and like, yeah, I didn't do it. Those were clients that the therapist had a very difficult time doing a goal setting, behavioral activation type of intervention. My colleague, George, then took this information and sort of, you're not usually supposed to do it this way, but he basically worked backwards and figured out like the behaviors that we were observing could be fit really nicely into these RDoC concepts. So negativity bias, affective dysregulation, And, basically cognitive control deficits were sort of the primary things that we were identifying. And that really helped us come up with strategies that the therapist could use to address those barriers. So working with the clinicians, we came up with this final design for the intervention Engage, where they basically, the first session is just a meaningful conversation with the patient about what their values are. Values are really important, by the way, because we were doing this kind of cross-culturally. We originally wanted the therapist to sort of focus on, pleasant activities, because that's sort of a thing that, CBT therapists are into. But the clinicians that we worked with who were working with Chinese immigrants said, that'll never fly. It needs to be value-based. So, doing something pleasant is hedonistic, but doing something valued and for the society is something they could get behind. So we decided, everybody can get behind values-based living. So let's make it that. As they're talking to the patient, they come up with like, well, you know what, of all these things that you say that you miss doing, which do you want to try this week? And so the patient, and again, there's some modifications based on culture. So for most patients, they would work, the clinician and the patient would work together to figure out what kind of goal they wanted to try that was fairly feasible, between sessions. Again, back to again, this meme in San Francisco, the older Chinese immigrants, we were told by clinicians is like, if a doctor says, what do you think you should do? Then the patient will say, you're a bad doctor. Why would I be the one coming up with the solution? Didn't you go to medical school or to like learn how to treat me? And so instead with the Chinese clients, what the therapist would do, and this gets at that kind of flexibility and error tolerance, they were able to go in and say, these are a list of things that I think you should try, and you can pick any one of these. Right. So coming from the doctor, but still giving the patient some agency over the choice. So what they would do is then, see how that went. The patient would go home. The next week they would check in on, did you do the activity? How did you feel after it? And if they responded well to the intervention, then the therapist just kept going. Okay, let's pick another thing that you could do. If they didn't, then the therapist and the patient will work together to figure out what got in the way of successful execution of the activity. And they would work together in a shared decision-making process to determine, was it something environmental? Like, have you got too much going on in your life and you need case management services? Is it negativity bias? So are there some cognitive exercises you could try before after you do the intervention? Is it emotional regulation? And so a lot of therapists got 100% behind Marsha Linehan's distress tolerance exercises as a means of addressing that. And then also with apathy, they really liked the motivational interviewing strategy. So again, not motivational interviewing, not DBT, but elements of those therapies that clinicians felt that they could do and learn pretty quickly. The whole process took about 6 months in designing this intervention, with about 3 months for the discovery piece, because there was a big survey as a part of it, and then about another 3 months for design and build, partly because they had to actually try out elements of the different what we call sacrificial concepts of the therapy, and come back and report to us about whether or not, what they would do to change it further so it would be a better fit with their clients and their setting. We were funded by NIMH to do a randomized non-inferiority trial to compare Engage to problem-solving treatment. We identified about 230 older adults with major depression and worked with 30 social workers in senior services, where we randomized them to be trained in PST and Engage. And so we have the typical clinical outcomes that you would look for. George added in looking at mediators around reward system engagement, because a lot of this was about getting people more engaged with rewarding activities. But then the pieces that Patrick and I were most interested in were whether or not we could change the time it took to certify therapists, and how many hours of corrective feedback did they need, and whether we can move the needle on that for Engage versus problem-solving treatment. Because this is not technically a pragmatic trial, or, and to some degree, it's sort of a weird hybrid effectiveness efficacy trial, because we do have this new intervention that we're testing. We did give feedback to the clinicians in PST as well as to Engage, but what we did is our outcome was to measure how often we had to do that, right? So the clinical outcomes, we basically found that that doing this user-centered design process did not break PST or the therapeutic elements. That Engage is actually non-inferior to problem-solving treatment. Okay, so that's nice to know. There was a part of me that kind of hoped that Engage would be better, but okay, we didn't. You can't always get what you want. But where our big bang for our buck was really in the amount of time it took to certify therapists. And we had some range there. There were some therapists, even with Engage, where we were just like, how did you get a license or how did you graduate? So that's why the number of hours is still a little on the high side on average, but compared to problem solving treatment, it's less. So if you were going to go to a senior service agency and say, we have this evidence-based treatment that would be effective for your patients, we would be able to say that this is about the number of hours you would expect a clinician needing in order to become certified. And then comparing that to other evidence-based treatments. Where I'm really excited about is that the engaged therapists had far less skill drift. So as we monitored their delivery of the intervention over time, we found that they were less likely to have any skill drift compared to the problem-solving therapists, even though we were giving the problem-solving therapists feedback along the way. Okay. And I'm trying to make sense of my time. How much, am I over time yet or no? Oh, at least a minute. Okay, great. All right. So let me give you another example, and I might have to blow through this kind of and this is directly from the ALACRITY Center. And what we were trying to do was is to figure out how we could increase access to evidence-based treatments in rural mental health in rural areas. So Southeast Montana was one of our partners. Originally Wyoming was, but they had to drop out. And then Eastern Washington. And these are actually two studies. The first was to to basically figure out, could we develop a bachelor's level credential, basically training program for people who had like a certification in alcohol counseling. And these are all people with, like maybe a college education, some of them not, in low intensity cognitive behavioral therapy for depression and PTSD. And that was a collaboration between myself and Deborah Kaysen, who is a leading expert in the delivery of cognitive processing therapy for PTSD in low-income countries. And then the second one was whether or not we could scale a training program in these credentials. And the main purpose of these two studies was to address the low workforce availability in rural areas. And that part of the issue that is, even though Montana was actually very invested in having collaborative care and integrated care in their federally qualified health centers, a lot of their patients actually lived 3 hours away from even that clinic. So integration in this context wasn't super anyway, because they had social workers like driving 3 hours out to see a patient, 3 hours back, and it was really not a scalable model. One of the FQHCs, Bighorn Valley, had decided, why don't we just use some of the community workers that we have and teach them little bits about how to do cognitive behavioral therapy or problem-solving treatment. And they were finding that they had greater reach when they did that, but we were getting a ton of pushback from the guilds, from social workers and from psychologists, saying that that is unethical. You shouldn't be, this is a highly specified and, intervention. They're right about that. You really need to be careful about giving these people responsibilities. It's beyond their scope of practice. And also the people who were in this position really felt like they didn't have a whole lot of access to people to support them in delivering even the low intensity cognitive behavioral treatments. It's a big challenge. So one of the things we did first was to talk to representative care managers, lay workers, chief medical officers, and the guilds and state policymakers in Montana and Washington, pointing out that this is already happening. There are complaints from, social workers and psychologists that this is not ethical. So let's discuss, but there's a purpose behind this, because nobody's moving to Eastern Washington or to Southeast Montana. So how do the conversation became, where's the bright red line between what a bachelor's prepared person could do and what should be under the purview of a licensed clinician? And just that simple statement really opened up the conversation, because then the guilds, who were particularly resistant to this idea, could start to get behind, okay, yes, I could see that there are circumstances where a bachelor's level person could support a licensed clinician for certain kinds of cases, but we want to make sure that there's some way that there's this good feedback between the lay worker and the licensed clinician so that we can intervene when we need to. We then did some interviews and passive inquiry with Yakima Valley Farm Workers Clinic, which is in Yakima, Washington. It's our big agricultural area, and Bighorn Valley, and asked them, so tell us about your task sharing model now. You know, what works? When does it not work? How does the teams work together currently? And what are the challenges in working together? So we basically found that the care managers mostly were like, I don't know how to do this. I'm being asked to do something I don't know what, I'm not trained to do. And the therapists were feeling like, well, I do a really good job already with the interventions that I've been trained in. But yeah, I get that the issues that make it difficult for me to work with my patients are social determinants of health, rurality and distance. And then, sometimes it's just low motivation because they're dealing with so many things in their life. So we engaged in a number of design sprints with, and in this case, this was just in Montana. And I should say that this is a clinic, so it's actually 5 clinics now. And in the population they work with are frontiersmen. Believe it or not, there is such thing as a frontiersman. They ride horses and, round up cattle. And people living in an indigenous population, so Northern Cheyenne and Crow nations were their patient population. And we had the groups work within clinic to kind of come up with strategies for doing this task sharing model, and then across provider type. And then we had a final validation meeting with a think aloud exercise where we walked them through this very complicated, but actually it's simpler than it looks, model of how they could do task sharing. And really the gist of it is this, that that everybody should go through a licensed clinician when they are referred for care. So that person could determine the level of acuity of the patient. If the acuity is high, then the primary deliverer of care would be the licensed clinician, but the care manager had a role in checking in on action plans, on making sure that they would come to their appointments, setting up ways for them to get contact with the therapist. So really kind of supporting the evidence-based treatment. If the patient was low acuity, then there was a model where the care manager, after some training, would be supervised by the therapist, the licensed clinician, to deliver low intensity CBT, just to see if they could get the person reactivated. And if they were still struggling or not getting better, then there was this immediate process by which the therapist would jump in. So this is a team approach. I could do some intervention and then be handed back to the clinician, to the care manager. One thing I failed to mention is that as patients who were in the high acuity group got better, they were eventually shifted off to the case manager, who would then do follow-up to make sure that their outcomes were, continuing to improve. So this is the model that they came up with. The intervention basically was divided in this way, particularly for the low acuity patients, where the top row of interventions basically was delivered by the care manager. And the bottom level of, intervention, like, having a significant avoidance, dysregulation, motivation, would be handled by the therapist. So this is something they could all get behind. So we got hit by COVID. And this is fairly qualified health center in rural area. So we didn't get a chance to really test it, that well. We only had, I think, about 30 patients that they tried this out with, where we could randomize them to usual care and the task sharing model. But we did find that from the clinician and the bachelor's level provider perspective, that they found the task sharing model initially was difficult to use, but after some practice of a month, the clinicians particularly were like, my workday is a lot easier now. I don't have to follow up with all these people. I've got somebody who can help me, and I feel pretty confident that this person can do a good job of a follow-up. In terms of the clinic, we found that there was much better patient retention and follow-up over time, and that patient outcomes, interestingly, everybody showed improvement. That's the downside of a small sample, but basically with no differences between the two interventions. But because the providers felt better supported in using this model, and patients were being reached at a more regular rate, it was seen as like, okay, this is pretty good. The big challenge, though, is how do we scale this? And I need to finish up, right? 3 minutes. Okay. I'll just go really, unfortunately, there's a lot. But so one of the things that I'll just kind of talk about this and then I'll skip forward. But, obviously this is great, but the clinic in Bighorn Valley actually relied quite a lot on Deborah Kaysen and my training the teams. And we're not a scalable asset. So we started to talk to, basically to community colleges and rural universities about the potential of them taking up this model of training and credentialing, bachelor's level social workers in this model and working with the partner clinics in their area. And the main thing that we came up with is that the community colleges were interested in this, but they said there's a couple things that need to happen. One, there needs to be a credential, and it needs to be tied to an incentive that people who get this credential would make more than they would make working at McDonald's, right? No point in going to school because their the students that they work with are often from the community. They usually have a couple of jobs. In Washington State, community colleges are free. I mean, there's a student fee, but the education itself is supported by the state. So, the cost of education wasn't necessarily the big barrier, but it was the time in education that was a huge barrier. And they really didn't want to pick a credential that, they could be making more money doing something, else. So that was important. And the other aspect was that the teachers who were in the School of Social Work said that there are aspects of social work that they could train to very well, but they weren't trained in evidence-based treatment. So how do I tell that these people are learning the competencies they need to learn? So we partnered with an engineer in computer science, a guy named Zoran Popovich, who'd been working on what's called an intelligent tutoring system. And basically it's an educational tool for teachers. He'd been developing this for public schools to help teachers uniformly teach basic algebra to elementary school students, as well as language competencies. But the way that the intelligent tutor works is that there's the intelligent tutor, the teacher, and the student. The intelligent tutor sends the student a task based on how the student responds to that task. The intelligent tutor starts to create a series of other questions that will help build the student's competencies. And based on how the student responds to those kinds of tasks, there's an adaptive algorithm that then personalizes the educational experience. So we're looking for what's called productive struggle, where the students are correct about 80% of the time, and as they get more proficient, the questions become harder. If they're really struggling, then the questions become a bit easier. And so this is a kind of a cognitive plasticity model of training competencies. We worked with, with 5 community colleges and rural universities to implement both our curriculum and the ITS. The way it works is that the teacher teaches the curriculum in the class. The students work with the intelligent tutor as a homework assignment. The teacher has a dashboard where they can see how the students are doing. And the teacher can have the opportunity to pair high-performing students with low-performing students so that the high-performing students can help the low-performing students, in those competencies. The ITS is actually a pretty effective tool. It tends to have equivalent effect sizes compared to expert one-on-one human tutors. It also tends to be equivalent to an attention controlled match that I created of educational materials. So I'm happy to share those. Those are really easy to distribute. But we did find some positive things in terms of student self-efficacy. They seem to acquire their competency skills a lot faster than students who didn't have access to the ITS. And in general, it's not great, but they like it. They can tolerate the intervention. And I'm almost done. We have now gone to the Senate at the state of Washington to create this credential with the appropriate pay lines for what somebody with a credential in behavioral health support would make, and it's above what you would make, flipping burgers. And it also is tied to the competencies in the training program we created at the ALACRITY Center. And it's just passed the House and the Senate, and now it's in Ways and Means. So I'll just skip through this really quickly. We basically are finding the same sort of effects across all of our studies that we fund in the ALACRITY Center. And happy to share that we've been publishing some of the data from there. But what this really means, I think, for the future of psychosocial interventions research is that, as we develop new interventions, and I don't want to, at all prevent anybody from coming up with something innovative, all I would ask is that people think about how resource intensive the intervention is, what is the skill set that is needed for somebody to deliver the intervention, and what are the challenges they're going to face in trying to implement it in different service settings. Because that will be, basically proactively collect that information about intervention needs so we can get away from these really complicated implementation strategies that I've seen popped up in the past few years, where sometimes those strategies are more complicated than the intervention. So if we could, as long as we have the information about what needs to be developed or supported, earlier in the process, we won't have to have these super complicated interventions. So you can see all of this information on our ALACRITY website. It's just uwalacrity.org. That's the team. And here's my email if you want to ask me any questions as a follow-up. So thank you very much.